This is Matthew Holt. I am the founder and publisher of the healthcare blog. It's THCB Gang. It's just after 1 p.m. on December the 2nd, 2021. And here's my lineup for the gang today. We just lost Jennifer Benz. So we have with us, though, for an hour of conversation and fun, Robin Farmanfarmaian, speaker, author, patient, and CEO. Michael Millenson from Health Quality Advisors, and Mike Magee, medical historian. So tell us a bit about what he's been lecturing about lately. So we're a small but mighty team today, and I will point out I have a bunch of stuff to bring up today because I've been thinking about all kinds of stuff like the role of private equity, and I've been thinking about the cost of emergency rooms and this, that, and the other. But I can dig into that. But let's go around and figure out who has what to say about what. I will start with you, Michael, then we'll go to Robin. As Mike just got the link and crashed in late, we'll give him a chance to compose himself. But Michael, what have you been looking at?
Clearly, the big news is that we're going to look back at how scared we were of dying from COVID a year and a half ago and see that as the good old days because of the new contagious virus. And historians will wonder, so let me understand, you go from thinking you're going to die to thinking that a vaccine that saves your life is infringement on your freedom. Can somebody explain that? We've got Biden ready to expand Medicare, apparently never having heard of the fact that the government paying for something will cause the demand to go up and the prices to go up. But he will relearn elementary economics. And then we have the rest of healthcare, where apparently venture capitalists and private equity firms are playing spin the bottle in terms of buying each other. So wherever the bottle lands, that's who you buy. So it's kind of an adolescent game, but with real money. It's interesting times.
Fantastic. All right. Well, a bunch of stuff to pick up on there. Robin, what have you been looking at lately?
So, of course, my eyes are on the insurance having to pick up the COVID testing. So that's a very interesting new development that came out today. And of course, I just finished writing my 4th book, Leveraging AI to Democratize Healthcare. Thank you. And so
I do have a question. Mike, it took you 25 years to write one book, and Robin's written about 4 in about three days. So what does she know that you don't?
Exactly. It's a great time. You finished writing it? When does it come out, Robin?
So it probably 5 or 6 months. It takes a while to go through the proofreading and then the formatting and pre-marketing and stuff.
I'd love if you send me any sort of advance after we're through. I'd love to see what you're writing about. That'd be great.
Absolutely.
I've got one sitting in my inbox, which I haven't looked at yet, so I should have it. Right. Anyway, so that's good. So actually, say a word about the book, and then you have one more thing, Robin.
So it's called Leveraging AI to Democratize Healthcare, and it's about the shift in care from the clinic to the point of the patient. And within that, there's so many cool things going on, but I'm really looking at vocal biomarkers and the role of AI voice technology in healthcare.
Great.
I've actually been, I got relatively recently, I was sitting in Milan, which is where I was having a post trip, and I got accosted by somebody who's talking about vocal biomarkers, somebody who works for Wobot, which is one of these text-based therapists. And they were telling me that the PHQ scores and the GAD scores, which is the depression scores, and the anxiety scores, which I just found out about, and now was and now I was boasting to people about how I knew all about it. Were actually all rubbish, and the vocal biomarkers were kind of the way that we're going to figure out who's depressed and who's healthy from now on. So I'm interested to talk a bit more about that. Mike, thanks for coming on. Sorry we got you the link so late. What have you been up to lately?
Hey, my apologies for being late. I actually have a good excuse, which is tied to what I'm thinking about. I gave a hour or 2-hour interview to a group that is doing a 20 on 20. They're calling it a review of the response to 9/11. So they're collecting stories 20 years later on 9/11. And they wanted to interview me because I had done a book called All Available Boats, which documented the largest maritime evacuation since Dunkirk. Some 350,000 to 500,000 people evacuated from Manhattan Island on 9/11. where I interviewed both the boat captains that spontaneously coordinated with each other to pull this off, which is a story in itself, but also the people who entrusted themselves to these boat captains. So anyhow, it drudged up a lot of old images and memories that are not particularly pleasant, and reminded me of all of the people who not only suffered from those images, if you were anywhere near it or experienced it, but also the people who worked on the piles who suffered mortal injury and mental health disasters as well, because there's a combination of cancers, pulmonary problems, and suicides that followed this, which continue, by the way. Anyhow, the guy who's leading this is a firefighter, former firefighter who does media now. And it's for a podcast. And at the very end of it, after 2 hours of talking to him, he said, "Would you mind if I call you back in a couple of days? I wanted to talk about the fact that I had leukemia diagnosed 10 years ago and treated as a result of being on the pile. And I've been cancer-free. And I got a call yesterday that the cancer's come back." And so it was a reminder, you know, that that day, at least my part of the story that I wrote about in All Available Boats, kind of emphasizes that human beings in general came together remarkably well. And I was really proud of what we did as a species. But at the same time, there was one little story that I recounted of a guy who noticed that on a tugboat that he was on being transported to Jersey City, there were 3 passengers with him who were of Arab descent in this boat with maybe 150 people on it. And some of the passengers insisted on seeing what these passengers had in their briefcases. And it turned out they were just books, but the fear was serious enough that day that people were afraid that these guys who were of Arab descent might have been terrorists. And I wondered, long story short, whether some of the difficulties that we're facing nowadays with pandemics and with our response to it and with the leaders that we've thrown our weight behind in the distant past, that the seeds for those kind of choices, you know, the choice of fear over future, may still be the result of what happened 20 years ago. So that's what I was thinking about.
That is, I would say, both deep and, you know, prescient. I didn't know you wrote a book. I saw the Boatlift documentary, right, the Tom Hanks version. But that's amazing. An amazing story of that day, right? Absolutely. And I think you're right. There's a lot more fear painted the other. I mean, maybe there isn't more, but it's a lot more present and obvious now than it was 20 years ago for sure. So, 20 years and change ago now. Absolutely. All right. Well, the things I've been looking at this week are a couple. I just sat in on a Dave Chase and Al Lewis webinar about you know, how do you manage costs, and I had forgotten about Al Lewis has this little phrase you're supposed to write into the terms and conditions when you go to the emergency room, which limits your cost to twice Medicare. And when my kid got his, there was a story about expensive stitches on NPR this week, and it was blamed by Olivia Rosenthal. It was blamed on the fact that it was a private equity owned hospital and a private equity owned medical group that did it. But the guy got 6 stitches for $6,000. My kid got 4 stitches for $5,000 in a nice Marin District nonprofit hospital. So I'm not sure that private equity were absolutely the blame for high costs. But although I'm pretty embarrassed that I knew about Al's idea of writing your demand in and saying, if you don't treat me, it's MTLR and you do have to treat me anyway. And then apparently he says it's been used 200 times and people always get treated, and because they've written in the contract law to pay them double Medicare, it costs them several hundreds of dollars rather than thousands of dollars. We'll see if that works. Anyway, so there was that. And then at the same time this week, there was this deal where Athena Health, the Jonathan Bush's previous company, which got bought by Elliott Capital Management and then got bought by a couple of other, and ended up now being sold to Bain Capital, H&F, another private equity group. It was bought, clubbed together with another organization for about $6.5 billion in 2018. 3 years later in 2021, and this is for essentially a practice management company that does some EMRs for doctors, doesn't do much inpatient stuff, nowhere near as much revenue as Epic or Cerner. It's just got sold for $17 billion, which is nearly on the way to 3 times the amount, 2.5 to 3 times the amount. A lot of sort of questions and answers about how did it manage to get sold for that much, and who made that much money, and what was going on in the world of private equity coming. So I think a conversation about what private equity is doing in venture capital is something that I wanted to get into a bit. So why don't we start?
Have you also, as long as we're talking private equity, just like things go across sectors, have you seen the whole controversy about private equity buying up apartments in America and in Britain and everything?
Yeah,
and raising rents and all the rest of that. So, I mean, in a sense, some of this goes back to what Mike was talking about, which is a sense of public good and ourselves as a society, as opposed to every person for themselves, whether it's in looking at other people as the other or just money.
Well, I mean, we've heard a lot about this, right? So we have, and at the same time, by the way, as this is all going on the private equity front, I'm watching, and I'm sure those of you, because I look at it so closely, the public digital health companies, which at the start of this year, were doing super well. Teladoc, which is the biggest one, was at $300 a share. Today, it's below $100 a share, right? So We've seen dramatic falls in the public market. All those companies that SPAC'd out, at $10 a share, $12 a share, like the 23andMe or Owlet or, ShareCare or many of those others, or Talkspace, which is for the most, are off again, 50, 60, 80% off their highs. And yet we're still seeing in the private markets, $100 million here, $100 million there, as valuations that actually now starting to look at bigger than comparable, if not bigger, companies on the public markets. So you've got to wonder how that is playing out. And this is all, by the way, in a system, and Jeff Goldsmith wrote a piece about this on THCB about a week ago, where, by the way, healthcare inflation has actually gone down compared to average inflation. It's gone below the level of CPI for the first time in many years, because over the last year or so, actually costs of healthcare, the overall spend on healthcare has gone down. Now, a lot of that was obviously related to the pandemic, just less spending rather than prices going down. But nonetheless, there are some changes there, and I'm wondering, how much all of this keeps going on. And as you say, Michael, in the housing sector, right, where we are now seeing, crazy stuff. So, for example, a guy I know moved up to my little town, sold his house to a private equity company, which gave him cash for it, so he could make a cash offer to the place he wanted to buy, because if you don't make a cash offer around here, you can't get a place. And the place that he sold it to, the company he sold it to, now sells it. And if they sell it for less than they think, he has to pay a bit back, and they get a share of the upside and what have you. And you remember Zillow, which was the real estate company, which was kind of doing this, made some big losses by paying too much for houses, and so it's definitely a strange time, right? Where there is so much money around, it's chasing returns in healthcare in all over the map of the economy. And it's just it's strange that we're seeing this happen so much. And that bit of healthcare where either it's around emergency room billing, or it's around buying technology companies in healthcare and seeing if you can flip them to the next private equity company. It's just a sort of strange way to think about how we're actually running the system.
You noted that healthcare spend went down. It was because of the pandemic. Does the group, anybody want to place a small bet on when someone says healthcare costs went down this year because of all the efficiencies from the organizations that started up in 2021, just like they promised us? they cut total healthcare spend extraordinarily. And those private equity firms were smart investors. They were able to get 10 times the money and cut total spend. We are grateful for that. Anybody want to bet on that headline?
We've just heard you say it, so it must be true. Fantastic. All right, let's dive in a bit. You both mentioned, both you and Robin mentioned, and you did before we came on the air, Michael, talk a bit about the world of AI and the world of how that's in the patient engagement. And one of the companies, there's a company called Luma Health, which does email-based sort of patient outreach, was one of these companies in the recent, I think last week or earlier this week, raised over 100 million. We're talking about now very small slices of technology in a wider area of healthcare delivery. So, Robin, perhaps you could, you just looked at this, you just written a book about it, expand a little bit about how you think these types of AI programs, especially around the patient outreach part that you know so much about, are getting used, and where we are in that transformation. And then I know, Mike, you've been talking to some folks at Converse and others you can weigh in as well.
We're still at the very, very beginning of that. I mean, if you talk to the average patient, they probably would have no idea what you are talking about, right? So we're still at the very beginning where you can walk into a hospital and you check in with your phone, right? And you're able to pay your copay without talking to anybody. And that's just even at the very beginning. So these patient engagement by email, it's awesome for a start, but come back to me in a few years.
So when you say that, what are the areas that you think? I mean, I know that Michael mentioned Converse Health, which now got bought by Amwell. There was another couple of companies I've looked at, one called Nuno a while back, which got bought by varying.
Twistle got bought by Health Catalyst.
Right. So much of them are getting acquired. It's like slices of a product offering.
Right.
Where do you think the impact the first impact that we're seeing where people are going to notice this? And the other area that I've seen is companies like Wobot doing this for chatbots for mental health. Give me a sense, Robin, when you look at this, where do you think the impact is coming first, and then where do you think the impact is going to be biggest?
So I think it's going to be more around the digital therapeutics and the vocal biomarkers, or the AI voice technology, before it's at that whole patient engagement stage between the clinician and the patient. It's these other things, these digital therapeutics and the Amazon Alexa being HIPAA compliant, are in the patient's lives on a daily basis, right? And so that way they're able to engage. When you've got something just like working between the clinician and the patient, it's an every once in a while thing. And so that's why it's much harder to adopt. But if you've got a digital therapeutic, and there are some of the smaller PBMs already reimbursing for it, but some of them are paid through the prescription drug formularies of the large employers, right? And so all of a sudden, those can get a lot more traction, right? And they're all just based on basic CBT, cognitive behavior therapy. But it's really engaging people with those chronic diseases that have that behavioral component, right? Whether that's diabetes or depression.
Is your Michael? Sorry.
Yeah, I think it's really interesting what you said. So let me try to tease out a couple of things. I think when you're talking about engagement for like post-surgery or something like that, that's kind of happening. It's IVR and it's email and it's text, and it's a lot of AI-based kind of stuff. And then you go up from that to, well, am I continuing to engage you for something like diabetes or hypertension? And that's where I think these companies got the money, bought for them, because that's a continuing engagement thing. And that's with the clinician, that's continual, right? And then you have, some of the pharma companies that want to buy that, right, for the MySugar, things like that. And then you go a little bit over, that's just the conventional care, right? And now you go over to digital therapeutics and digital biomarkers and the clinical trials, which is a little bit different, but the clinical trials are people who are willing to pay a lot of money on it because it's pharma companies, as opposed to hospitals, which it takes you 2 years to sell something that they're willing to pay 95 cents a patient, maybe, right? But so you start to get it, and then the thing, and I actually saw a presentation from Twistle this morning, which is what I see is, and I do some consulting to Health Catalyst. What I see is interesting but do the hospitals want it, right? Because patient engagement that we're talking about now is how can I get the patient to do what I want them to do, right? It's compliance, adherence, engagement. It all means I want you to take your medicine. I want you to be in my clinical trial. I want you to tell me if you're in pain so you don't cost me money. That's all the engagement stuff. But what you can also do is if you start to put in patient-reported outcomes, now you can use that in a systematic way to judge whether clinicians are doing their job well or whether a certain procedure is working or whatever, apart from that clinical trials. And now you're trying to change physician behavior or say the hospital or something, right? And Mike knows all about this. And so now that's a whole different thing, but who's going to pay for that? And then finally, you've got what that old-fashioned thing called patient empowerment. Well, why do I want to pay for you to be empowered? You might choose to take a different drug. You might choose not to get the procedure. You might find out that there's a better doctor somewhere. So as much as we talk about this empowering patients, it empowers patients right now within a fairly limited paradigm. Now, who could pay for real empowerment? Well, the employers could if they actually wanted to pay money. The plans could, except maybe you'll go outside the network that I have and find out that I didn't choose everybody based on quality, right? So, and patients expect everything to be free. So, when you get to how are patients really going to be empowered by this? A little bit, some. As Robin said, it's coming. It will come. I believe open notes and everything else is going to blow everything up and everybody's going to be empowered and collaborative and democratic. But right now, that's not what they're paying for. They're paying for, I can control the patient's behavior and make money. At least that's how I see it. You all may have a different take.
Yeah, my thinking on it is I'm sort of coming at it more and more from the other end, maybe because I'm from such a large family. My wife's one of 10, I'm one of 12. And we seem to be inheriting the long-term care of brothers and sisters.
Oh my gosh.
So, it's endless. And so I tend to look at where's the consumer readiness, where's their real interest in engaging with anything that might give us a little bit more productivity and efficiency in our daily lives. Putting aside the doctors, the hospitals, and so forth, just human beings trying to get on with the fact that their bodies are deteriorating and you're trying to maintain your functionality, right? So what are people really interested in? They're interested in managing aging. I'm quite certain about that. And they're interested in managing their weight because nobody likes to be fat, really. And they're interested in managing their mental health if they feel badly. How can they feel better, right? So on the aging side, I had a very interesting experience because we have my wife's brother, we have the primary care responsibility for, and he has progressive supranuclear palsy, which is a rare and terrible disease. So he's at the point where we've brought in hospice. He's in a long-term care facility. And I love hospice. I first got introduced to hospice back when I was a fresh hospital manager back in the late 1980s. I love hospice. So I'm sitting there for the hospice intake interview because my wife asked me to sit in on it. And she explains to us what it means, which I never knew before, to sign on for hospice. And what it is you're signing actually on to a sub-branch of Medicare, whereby you get a wide range of extra services for the person that are really on point and needed. A psychosocial, 5-person team, including a chaplain and so on and so forth. And you're signing on for at least 6 months. But if you last 2 years, you last 2 years. If you last 30 seconds, you last 30 seconds. But the thing that I didn't understand is that the way that hospice gets paid is you agree no more specialists, no more hospitals, and generally no more tests. Okay, so if you have a urinary tract infection that someone suspects by virtue of the fact that the smell of the urine has changed, that's fine. That gets treated with antibiotics, but you don't do a urine culture. You sure as hell don't go to an emergency room, all of which is a fair deal, right? They're basically saying, look, you're saying this is end of life and you're moving into the final stage, and we're here to support you in every way. And we have vast expertise, and we have a broad team, and we have the services you're missing, even though you're paying multi-$1,000s a month in this long-term care facility. We're going to come in, we are going to layer on our care plan, and it's going to be the best, whatever it takes, approach to death that there is. But in return, don't waste our money. Don't do stupid things, you know. Don't be getting diagnostics. Don't be checking your blood sugar, even if you're a diabetic. It doesn't make sense if you're saying you're ready for this next phase. So anyway, as I was listening to that, I was saying, well, you know, I wonder if this kind of approach is applicable for other points of life. So that, you know, would it be applicable, for example, in the beginning of life, to really tailor services to what the real needs are for a new mother and a child? Like if we're applying this kind of 5-person psychosocial team to death, why are we not applying the same approach to life? Why would we not support mother and child for 6 months up to 2 years when life begins? Wouldn't that be, you know, a worthwhile expenditure of money if you would agree not to do certain things that are wasteful and make no sense for 0 to 2 years for mother and child? Anyhow.
Yeah, no, I'm not sure how you got that from AI, excuse me, AI, Mike, but I like the idea of what you're saying, because
well, you know,
we're essentially saying, go ahead.
In terms of investment in applications of new technology, you know, Matthew, maybe, you know, maybe the reason why there may be some applicability has to do with the longitudinal nature of managing care and keeping track of what you're actually trying to accomplish, I guess.
Yeah.
Maybe
well, I mean, let me give you another example, which is back at the other end of life, closer to you know, long-term care, which is a company just called Safely You, just got funded this morning, got $30, and some of it was prepaid revenue, or I think $40 million. $10 million was prepaid revenue from a nursing home chain. And we had, I don't know if it was them or another company like them I had at Health 2.0 in Japan, which is on my mind, because right now I should be in Tokyo getting drunk on whiskey and sake and enjoying myself eating sushi like I went with Robin a couple of years ago, and now I can't go. So I just gave the talk. You know, the conference is going on yesterday and today. I guess it's today because it's Japan. It's tomorrow in Japan, right? And I gave my little 15 minutes and was done with it without getting any explosive sushi or good ramen. Anyway, but we had this company which is then showing experimental. It was actually an American company showing experimental video-based AI to try to forecast falls in nursing homes. And now this company, Safely, I don't know if it's the same company or it's a reiteration of the same technology, or if it's a completely different company doing the same thing, but essentially got that. And what they're claiming is that with a combination of video and intelligent interpretation, machine interpretation of the video, they can reduce falls and emergency room visits for falls by, you know, a factor of 5. Now, who knows if it's true or not, but I mean, that's to me an interesting claim. But there's probably a similar thing you could do with intensive patient tracking using technology of mothers and babies to look for either outliers which are going to, you know, go wrong and go south and require help. And that probably goes, by the way, not just first 2 years, but previous 9 months, right? In that previous year, getting the mother in the best shape to have the baby, so you don't have low birth weight babies in the first place. And there's a lot of psychosocial and basic support and housing and food and who knows what you could do for that, but also so tracking going on. Now, if you look at where we're going with tracking, right now for sort of people out in the community. It's all people like, healthy people like Robin and unhealthy people like me who are getting now, doing their CGMs and getting their blood, the athletes who are tracking everything and the people who are doing the quantified self. But you probably could figure out a way to get that to a, more needy population and start thinking about doing that. And you probably could start to make a difference and we're really talking about surveillance, right? Tracking, surveillance, using intelligence to do that. And obviously we're starting with people, Michael's talked about people with hypertension or diabetes, but you could imagine that kind of deal could be converted. We could think about where we spend the money rather than, have people turn up in the emergency room for whatever.
So Matthew, our friend Brian Klepper, I was on a call with earlier this week, talking about a company that does exactly one of the things you're talking about. They look at women at high risk of premature birth, and they've reduced it by a huge percent because they can do the AI kind of thing and find out who's most at risk. And those are hugely expensive and tremendously reduce preterm births. And of course, it also is a health equity issue. So, that's another one of the inspiring things. A nation in favor of all health equity, which saves money. We believe all people should have equal opportunities as long as they're cost saving. It's really inspirational.
To be fair, right, you're hearing a lot of that rhetoric coming out of CMS. You're hearing a lot of that come out of the Build Back Better stuff about how this is to do with across the board to do with improving equity, and you're hearing that a lot. I know that reality on the ground is clearly not going in that direction at the moment, but I've been hearing a lot. You're seeing a lot of foundation funding for studying into different, improving health equity and across the board.
I'm back into the former Buffalo Bills quarterback, Jack Kemp, who was a congressman back when Republicans were different. Jack Kemp, who obviously is a former quarterback and worked with a lot of black people as his offensive lineman and other positions, right? Talked about the fact that equity and fighting racism is a smart thing to do economically, which it is. I mean, all apart from the moral issue, to take a large segment of the population and not allow them to be productive for arbitrary reasons is economically, ridiculous. And this country has built its prosperity on alternatively being totally afraid of immigrant groups and then assimilating them and let them being afraid of the next immigrant group.
Michael and Robin, I'm wondering, when you're thinking about these things, and let's say AI specifically, do you think of these in terms of leading to greater mobility of care teams? Because one of the things is that, a long time ago, not a long time, maybe a decade ago, I wrote a book called Home-Centered Healthcare, which was, the idea was that you base as much as possible in terms of your care system in the home. Now, besides many people thinking that was impractical, the other thing that they didn't like about it was the fact that some people don't have a home. Some people have lousy homes, you know what I mean? But the idea, I think, still was basically sound that if we could get greater mobility out of the workforce somehow, that a lot of the problems or issues that need to be raised could be raised by a mobile workforce rather than by brick and mortar, and that technologies as they developed could accelerate the creation and functionality of mobility. Does that make any sense from an actual?
That's exactly, yeah. That's exactly it. That's why the subtitle of my book is Shifting Care from the Clinic to the Point of the Patient, right? Because we are going to get a lot more of democratization and health equity when we can actually reach people who need it the most, right? People who are a couple hours drive away from the nearest hospital and they have no transportation to get there. But the way I also address this in my book is we have to remember penicillin was discovered in 1928, right? It hasn't even been 100 years. It took decades for that to be widely distributed. That was one of the biggest things to happen in healthcare, right? We can't expect the democratization of healthcare and health equity to happen in a 5-year period, right? This is a multi-decade period to really be able to reach everyone. But these AI solutions starting to become more popular and more people using them will eventually be able to reach people. It's not going to happen overnight. It's going to take time.
I think it's really good, Robin, that the whole expectation of fast change. And there are two issues. One is you're disintermediating people, and they don't like it. And two, there will be side effects that are not good that we don't like. And part of the reason to which we don't get universal health care in this country is that even if you came up with a solution that helped 99% of the people, we're better off, and 1% weren't. The 1% is a lot of people. You hire lobbyists, for the people, and you tell horror stories, and that moves people. Well, what about Mrs. O'Gillicuddy in Kansas there, right? And so there'll be the positive stories. The people whose economic wealth is being hurt will tell the negative stories. One of the things that I remember reading, we talked about standardization, interoperability. I know Mike and obviously Matthew's been that, is when during the Civil War, under the Lincoln administration, Congress decreed that all the railroads have the same gauge of track, right? So that they could connect, okay? And what this did, and Senator Manchin would love this, what this did is there were people in Pennsylvania whose job it was, where the two railroads came together, to unload people from one train and take all their bags and put them onto the other train, right? And you put those people out of business. How dare you put out our train unloaders, who are some of the best working class train unloaders whose families are depending on them, because you want some sort of standardization of railroads, and God knows what they could have done on Twitter, right? And so, that's the problem we face, is that things which may be revolutionary in the long run and good in the short run, somebody with a cell phone camera will lose out.
Well, I hear that on the train thing, apparently that the gauge, which is relatively narrow, is based on a Roman chariot, because the Roman chariot, the roads that were built, it was based on the original roads, and the roads came from the Roman chariots, and so that hasn't changed in 2,000 years.
So I'm sorry, what you mean to say is that the gauge of our railroads is based on aggressive behavior by white males? Is that what you're endorsing? You're endorsing us putting these working class people out of work for a white male European gauge railroad?
I don't know why nobody has hired you as a lobbyist, Michael. They might think you're a little bit over the top. Having said that, I live in the one place in the world where the train gauge is different, where BART, which is the Bay Area's, Bay Area,
really
has a different gauge. And of course, they can't get in order to make any of their stuff. So they basically end up, by choosing a different gauge, or the cars are a bit wider, they forced themselves to become a production company to build new stuff, because no one else is building stuff. They can't just go and put it out to bid because no one's making it. So standardization matters a bit. The chariots were okay.
Where I live, there are a number of good commuter railroads into Chicago, all of which run on the right side going into the city and the right coming back, except the one near me, which is English style and runs on the left going in. And the very first day that I moved here and took the train, I stood on the right and watched the train go in the wrong direction on the west. So if you ever want to feel, at home in Miss England, if you take the North Line commuter train here, Matthew, it is English style.
I can't wait for that. Of course, the greatest example of this is 1958 in Sweden, where they used to drive on the left, and they changed to driving on the right overnight. That must have been quite a fun morning. All right, we seem to have got a bit away from where we were, but we were talking about, I think if I remember rightly, we were talking about standardizing care and see if we can do better with AI for equity. I am a little concerned that with the AI tools that I'm seeing at the moment, that what most of them are doing are giving, from the AI chatbots that we all use, they can do some basic stuff and they can route you, but it's really, they've chatboticized a book, essentially. They haven't really, or they chatboticized CBT, which you used to do in a manual. And while I'm all for that, I'm all for delivering, more information to people they can access themselves, and a chatbot is a good way to do it. We haven't quite got the brain. There are some complex stuff in many of them. We haven't quite got the sort of, the human part of the brain where I can say, aha, we need to do this. And we've all had the experience of being on a sort of retail chat thing where we've been on the chat bot and it said, oh, you have to call a human being because at this stage we're giving up. And, so I'm a bit worried that, that's the thing we're doing, and that the more ambitious and perhaps, valuable part of sort of really assessing all the data and figuring out what's happening, and can we deliver interventions that people didn't know they needed, or do diagnostics in a better way, using AI for radiology. I don't know, it's a bit further away and we're not seeing so much impact on that. Am I wrong, Robin, or is that?
No, you are right? So think about this as—
That's why I invite her on the show, because she says things like that. Sorry.
I mean, think about Facebook 2006, right? That's kind of where we are, is social media 2006 or MySpace. So, give us 5 or 6 years to really start to aggregate and get these massive databases. Give it a couple more years of interoperability, right? Big partnerships with things like Microsoft, really moving the needle. And in terms of the AI modeling, right? So the reason you're getting, it looks like it's just pulling up, a chatbot pulling up parts of a book or something. It's because they're not using the most advanced technology. Right now, we've got programs or AI models that like GPT-3, which is able to actually come up with its own unique text based on, a massive database. And so that's kind of next generation, but no one's using GPT-3 that I'm aware of in healthcare yet. We're still on, kind of like the little bit old school stuff.
I'm a bit worried that Robin says we're at Facebook 2006. If we're getting, what's the AI equivalent to Facebook during the Brexit and the Trump election? I'm a bit worried about that, but anyway.
Right.
So the one of the things that, to go build on what Robin was saying, Mayo Clinic has the most detailed medical records of anybody, because they started having a real comprehensive paper patient record back in the early 20th century. And they are now trying to digitize some of that information as part of their partnership with Google, which is really kind of interesting. And obviously a lot of other things. So there is some of the AI being used in diagnostics and personalized therapeutics. Some in the cancer realm obviously is high value, some elsewhere. But again, the business case for that is difficult, because if I, as a physician, am already coming up with the right diagnosis, what do I need you for? Now, we saw that with the case of IBM Watson, that's exactly what the case was, is that they really weren't adding value to oncologists here at all. And that's why they ended up trying to sell it to third world countries or something like that. So it's a difficult task to do if it's not something that's relatively clear cut. Like Mayo came out with something earlier this year on some particular cardiac symptom, I think it was. So if you take like a narrow slice, yeah. If not, I'm going to go to Mike and ask him what to do.
But you guys, what percentage of the new ventures sort of embrace still the idea of build it and they will come?
I mean, a lot, right?
I mean, is it like 80 or 90%? What is it?
99.
It's a big number, but there's an issue here, right? I've been looking at this a lot in the mental health space. Doing a little bit of work in there, and it just seems, which is why I know what a GAD score is and a PHQ score, even if I now I've been told they don't say what they should say, but which is the depression score and the anxiety score, in case you don't know. PHQ is depression, GAD is anxiety. Look at that, I could go to medical school now. I'm done. But in that area, we've got a really big problem, right? Which is, number one, poor diagnosis of, there are different types of mental health problem, and they are not properly diagnosed. And many of them have solutions. Therapy-based, drug-based, some combination of drug and therapy-based, whole bunch of new drugs, well, not new drugs, but old drugs, the psychedelics, like ketamine and MDMA are coming back into the fore there as well. So there's that. There's extreme pressure on accessing therapists and accessing psychiatrists, just there aren't enough of them. So a lot of this stuff is we're going to have to turn into some kind of self-service, and that's what, the Wobot chatbot and other things that kind of do. CBT is doing that a lot, because we just don't have enough human beings to deliver it. And we've also had an extreme increase in demand over, and whether this is cultural, just COVID-based, or it's generational, people, I was kind of kidding with, there's a new English company called ESO, which just, the NHS is just going to sort of license and use across the board. And I was kidding with Jessica on the show when they got funded there, 60, 70 billion dollar round. In my day, the British had a stiff upper lip and you didn't talk about this stuff and it was fine. But apparently the young English kids are now talking about it, it's all different. But if you look at that, if we don't have a way of doing practical self-service at scale using technology, we're never going to get to the level of treatment that we're talking about. I think the same thing is true in the sort of, Robin is talking about moving from, the point of the hospital, the physician's office to the point of the patient. But there's also a parallel thing, which is the continuous nature of the care being delivered rather than the point in, the at time intervention. And we have to keep tracking whether it's whatever kind of biomarkers, vocal or, regular. We're going to have to keep tracking those and figuring out what all that means. It's a very different way of healthcare to organize. But if we don't do that, the possibilities of doing things at scale, especially where we're limited in access, and we talked about health equity and access is a big part of that. Yes, you can always argue that there's too much healthcare done, too much of certain types of healthcare done, and we should be doing less and therefore using those resources to do other things. But nonetheless, therapists and therapist shortages, there are strikes in Kaiser Permanente because the therapists think they're overworked and they don't see enough patients, overworked, and it's too hard for patients to get in. That is a real issue, which is happening right today. So this kind of, to me, is, build it and they come, and a lot of stuff is like that. But if we don't figure out this kind of technology and service-based solution, we're going to not get any better. And in some of these areas in healthcare delivery, we're in bad shape.
Well, isn't the pandemic sort of pushing us in that direction? First of all, more need by virtue of the isolation, but also more comfort with forming relationships virtually like this.
I would agree, right? I agree. I'm just thinking of this. Mike, you and I have never met in person. Yet we've been doing this for so long. I'm not sure it would make any difference, right?
And employers are also coming. I put a piece in Medium this week that employers are starting to cover mental health benefits more and more because otherwise the human capital breaks down. Right? Yeah. It makes sense. I think they're doing it for two reasons. I think they're doing it obviously because the need is huge and they see it. And frankly, the people who make these decisions have the same needs themselves, right? The HR people are not having happy lives at home. They're feeling the same stresses as everyone else. And I think that, when you have something that affects everyone, that can cause a little bit more compassion and empathy. And you see that, I think, in the corporate benefits world.
Yeah, I think that's very true for mental health. I don't know. Robin,
it seems like,
Robin, go ahead, sorry.
It seems like we're not admitting that some people just want to be left alone. We're basically saying, well, who wants to spend money on a long commute or and we're sort of still believing that people really want to get together with each other in a workspace. And I'm beginning to suspect that people are getting pretty used to not having to do that. Like when you have Wall Streeters that don't want to go to Wall Street, that's pretty significant. Those people are aren't they the most inclined to be in the battle zone, and yet they don't even want to go back to the battle zone.
So Mike, my son works on Wall Street, and he's single. I don't know whether you lived in New York at the time of 9/11, or most New York apartments for people who are single will encourage you to go to work. Hell, you want to go to a restaurant, to go to a bathroom, it's bigger than what you've got at home. Right? So part of it is that who are you? What's your living situation? Yeah. Where are you in your work life and all the rest of that? So when there's, virtual meetings, if Matthew never networks again through a virtual meeting, his contact list will stall out at 10,000, right? But on the other hand, if you're 24, it's tougher. And if you're 24 and you're at the meeting, you can be in the line next to Matthew and he'll talk to you. If you're 24 and you're at the meeting and virtually, who's going to hang out doing the networking? So it all kind of depends where you are in life, I think.
I think a little bit. I do think there's definitely a need to, humans are social. There's a need to get together. There's a need for free drinks at the bar. That's all the rest. Now, do you need to go to a single office every day?
Right,
you know,
right.
and can, on the healthcare side of things, right, can you have a more rational distribution of visits? There was always the old joke, talking about Japan, because I was supposed to be there, the old joke about the old Japanese ladies looking around at the hospital, all looking at each other going, where's Mrs. Tanaka this morning? And she's saying, someone says, oh, she couldn't come because she was sick, right? The social aspect of going out to healthcare and people visiting. I think when we actually first had the pandemic and people couldn't go at all, and then people started going back to the doctor, there was a lot of, well, I want to get out of the house somewhere, right? Somehow, to go to the doctor. But in the end, the concept of doing, whatever it is, every 3 months, every 2 months, visits to people with chronic illness, when you could probably do monitoring that's much more automated and then have them come in for serious stuff. Have them
So
out of the teams.
will we change, will virtual care change this whole nutsy thing with hospitals where the doctors operate Monday through Friday, and Saturday maybe somebody will see you, and Sunday the rate doesn't go down, but nobody sees you unless you're dying, right? I mean, are we going to end up with, okay, I want to work 3 days a week, so I'll work Saturday, Sunday as a nurse or a doctor operating, but I'll be off. Are we going to break through the old routine of in-person care at hospitals, do you think?
Culturally, that's going to be tough, right? But at some point, if the job of the healthcare services organization, or as I call it, the continuous clinic, is to look after people wherever they are at whatever level they need, most of that is going to be done by sort of remote virtual sensor-based, biomarker sensor, whatever it is, based tool. But we're so far away from that because we're still not paying people now. And the reason hospitals, don't forget, had to get people back into their buildings, in the summer last year, in the fall of last year, and then, was because they weren't doing the elective surgery where they made all their money. So there's so many, and we haven't really substantially changed any of that.
I realize we can address the workforce shortage. I think is we have a special wing of unvaccinated healthcare personnel. And that if you're anti-vax, you get to see the unvaccinated people for your care. And by the way, it turns out that the unvaccinated unit is also owned by a private equity firm. So you don't have to deal with that terrible nonprofit. You have a market-based healthcare system of unvaccinated people who are practicing their personal freedom, and they're ready to take care of you, the believer in not being vaccinated. I think there's a market niche there, Matthew.
I will find some venture capital funding
You do that.
For you, just for that one there, Michael. I think the private equity.
Maybe self-limiting.
Eventually, but one of the charts I showed for my Japanese talk, when I talked to the folks in Japan yesterday, was actually, I hadn't done this. It's quite sobering. So you all heard. I mean, I picked May the 6th, which was 100 days post inauguration, right? Because Biden said we're going to 100 billion vaccinations in 100 days or whatever. And the US was, I think, at about 50%, 47% at least had one vaccination by then. And maybe, it was into the 50s. Now we're in the high 50s, low 60s total vaccinated. The Japanese at that point, Japanese now are at 80%. Do you know where they were in May the 6th? 3%. They were there with Bangladesh and Botswana and God knows what. So they figured it out. And they're still not letting foreigners in, hence they couldn't go. But nonetheless, we are way down the chart in terms of total vaccinations. I don't want to rehash in the last 2 minutes what we've talked about many times on this show about the unwillingness of certain members of our society to get vaccinated, but. You're kind of not entirely joking, Michael, about the parallel health system.
In Rhode Island, Matthew, it's 97.5% who've had one. So what we're fighting is what was the original fight back in 1781. It's a states' rights issue, and we can't get past it. We just can't get past it. And so we ride things like healthcare and refuse to rationalize it in the interest of continuing to serve at the altar of state rights.
And I wonder if with the Omicron, is it Omicron or Omicron? I didn't realize that I'm not going to university in this undergrad in this country. I never figured out my entire Greek alphabet because I was never in a fraternity. So I didn't realize there are 2 Greek letters starting with O, Omicron and Omega. But if we get to Omega, we're in real trouble because that's the last one, right? But with with this, and it looks like it might be spreading worse again. We might have a few more waves. I don't know where we end up, because there's no appetite, clearly, politically or culturally or anywhere else, to go back into lockdowns. We have, as far as I can see, no appetite for 35-40% of the country to get vaccinated. I heard Jim Cramer, the stock picking guy, was saying it's time, we just got to mandate it for everybody and make it compulsory. And I said, I think this is a good idea. I got called a Nazi by a bunch of people. I said, well, in that case, George Washington must have been a Nazi, right? Because he wanted his whole army to be vaccinated back in 1782 or 1776 or whatever it was. But to me, we're still in that stuck phase. And Michael's kind of joke about the parallel universe for treating with COVID is going on. We've never not, since March last year in New York City, we have never not had some part of the country where ICUs have not been full of people, right? Houston and Texas in the summer of last year, Florida early this year. We've just, if you look at Colorado's just got up, it's still under the cosh, but Michigan's now got ICUs which are full of kids, well, full of people with COVID, and the rest of them are full of kids being shot at school. Talk about other social problems we have. So Jeff Goldsmith was on this program I don't think you guys were on me a couple of weeks back, and he was just despairing, and he was saying, Xi Jinping in China has got a much better idea about how to run a country. It was losing the plot about the fact that we're allowing people not to do it.
This, if you mandate it, Japan doesn't have a Supreme Court that's going to overturn it.
I don't know, the Japanese had to. They still have their social good. Yes, we didn't get into that part of the Supreme Court, and I guess we're almost out of time. Perhaps we can touch on that and then what happens next. But yes, that was something happened this week as well, which was the issue around the Mississippi, and eventually we'll get to the Texas legislation and what happens to Roe v. Wade. Yeah, all more good fun. All right. Well, we're nearly out of time, so we just have enough time to go around the four of us and figure out what we think is going to happen next. So why don't I start with you, Michael?
Well, we're going to have the Biden bill on how everything changes healthcare, and if that passes, it'll at least get some of the publicity off Omicron. But meanwhile, everybody's just waiting to see, what's going to happen. I mean, Delta became 95% of the infections in under 2 months, and they're now predicting that Omicron could be that way in 6 weeks. We'll wait until now. Maybe not. Maybe the vaccinations help. Maybe this, that, and the other thing. But it's really sort of the cliffhanger for the economy and for everything else. So that's kind of And meanwhile, Congress moves on to do what it does or doesn't do, and the Supreme Court moves on to do what it does or doesn't do.
Sorry, Mike.
Well, I think Robin's book is going to solve the states' rights conundrum. AI is going to be the answer. We
have to wait 6 months for it to come out. So we have.
Yeah. That's all right. It's worth the wait. We've waited this long.
Robin, what are you looking at next little bit?
Yeah, I mean, I'm looking at the new variants, but the good news is that we do have vaccines, and the mRNAs say that they could have a new vaccine by March, right, if needed. So that's all great news. We are much better off than we were a year ago.
That's clearly true. Well, I'm looking at that. I am also thinking over for my part, thinking the next few weeks. There was a very interesting court case, which has just got settled. It's the first round it's got settled between Team Health, which is a private equity-owned emergency room, which, by the way, was the one that NPR were complaining about in their $5,000 stitches, $5,000 for 5 stitches, whatever it was, piece, and United Health Group, which now also owns its own emergency room group. And there was a lot of extremely vicious rhetoric used by the jury and the judge about what United did in this case in terms of cutting them down. So the issue, I know we've talked about surprise billing and that kind of stuff and how much things cost and the role of private equity, but the issue of who pays what and who gets rewarded is going to continue to come up. And even though we've had some legislation on that, I think that this war continues. And hiding behind that is the role of health plans, more and more of whom are moving more and more into providing care, both from the sort of getting involved with providing Medicare Advantage, buying clinics, delivering care. and sort of, moving eventually to a world of Kaiser-like provision of insurance and care to some extent, but doing it in a world in which they have to, reward Wall Street. Michael's son is demanding that they, bump their earnings per share every week, and that's kind of the interesting world I think that we're merging into. So I think that area of who gets paid how between payers, providers, and what's the role of private equity and capital is going to have a comeuppance at some point, especially with the stock market and the digital health sector coming under the pressure it's coming under. But so I've definitely got my eye on that. And with that, we are almost out. So I want to thank my panelists for this week on THCB Gang, who were Robin Farmanfarmaian from the quiet Delta place, quiet downtown of Menlo Park, California, Michael Millenson from the mean streets of Chicago, and Mike Magee from the wilds of Connecticut. They have been your THCB Gang. I am Matthew Holt, the THCB founder and publisher at Baltimore on Twitter. We'll be back next week. Episode 74 is on December the 9th. Thanks for listening, even if you're watching this live, whether you watch the video later, or whether you are catching us up on iTunes or Spotify on the podcast. And we will be back in a week. Thanks for watching.